efforts have been made, and she is cheering us on. With that, we'll have you conduct the roll call.
All right. Chair Lewis.
Here.
Councilman Robinson.
Here.
Chief Butler. Chief Tobin.
Here.
Jason Brand.
Here.
Marissa Calderon.
Here.
Dr. Noggle.
Here.
Barbara Broderick.
Here.
All right. We have a quorum, Mr. Chair.
Thank you. As noted, or maybe they don't have it on their sheet, the minutes from our last meeting have not yet been compiled, almost, and so they will be part of our next meeting as far as approving the minutes. And so in looking at the presentations today, we're
Conjunction with public health to look at child abuse and neglect or endangerment cases where an opioid is the underlying cause, right? So our folks who are, kids maybe are getting into the Narcan or they're passed out and, police are responding. Again, no dangerous crimes against children cases allowed. These are concerning cases, but no significant physical impact injury to the child to be referred. Parenting skills, those are veterans, domestic violence, just really focused in on a particular offense. Veterans, just a particular population. We coordinate with the VA's office to get the individual connected with the VA if they aren't already for wraparound services or ongoing support. Service non-payment, so our providers have a fee, right, for their services. About 60 to 65% of our participants are enrolled in Mercy Care or have access coverage, and so the state's covering the bill for that. We do currently have ARPA funding from the feds, and so if individuals complete a financial assessment, we can help offset the cost and use those federal funds for that. But if you're not paying the fee to the provider, they give you some lead time. They let you attend groups while you're in arrears up to a certain point. You got to pay your bill, and if you don't, then we're discharging you. So that would be another unsuccessful.
So there are then providers for anybody who is income eligible or has access.
Correct.
There now are providers. So anybody in the felony diversion program is not limited to go through diversion because they can't pay for their treatment.
That's correct. That's correct. So
when did that, because that's a change.
That is new. That is absolutely new. So prior to COVID, diversion was defendant pay, right? And then we got some federal funding, and we raised our hand and said, let us use some funds to offset the cost of diversion. So for some folks, we pay 100% of the cost because that's what their income shows us, but they're not eligible for access. 75%, 50, 25%, whatever it looks like. But we use ARPA funds first.
And is Task still the provider for drug screening? And do those drug screens have to be paid for by the person that's participating in diversion?
So Task is not a provider. We use AverHealth right now as our contract for drug screens. That's for in-state people as well as out-of-state. So you can be an out-of-state participant in diversion. It's a little more complicated, but you can. But we use AverHealth for our out-of-state drug screens. And right now, while we have ARPA funding, we're covering the cost of the drug screen.
Okay, thank you.
So you just led right into the question. So what's the outlook for that federal support, filling that gap? And then the next step would be then, like, what's the county's plan if it's not looking good for funding?
Sure. So we have projected use of ARPA funds through the end of 2026. So we've allocated all the funds that we've received and said, here's how we're going to spend it up to the end of calendar year 2026. We do and have had conversations about approaching the Board of Supervisors for funding in our overall office budget to help offset some of the defendant cost for diversion.
Thank you.
Of course.
So do you think that when ARPA funding goes away and there's no new funding source, that would affect the numbers again?
It very well could be.
Because
It absolutely
then
could.
The offenders couldn't afford the program, right? 'Cause
Potentially.
there's no offset,
Right,
and that they would not be able to participate, right?
right.
If that happened. So that would be a factor that influences this if you don't get funding somewhere else.
Yeah, so, the hope is, we get the support in the budget after the federal funds are gone. But if not, then we go back to individual pay as it was before, and then you will see an impact in the numbers. It's just, that would be unavoidable if it went that way.
And then just one other question. You may not have these numbers in your head, but for the SMI felony diversion, how many people are being engaged in that program? And if you can't get it, you can always get it to us later.
Yes, I will get you an exact number. Off the top of my head, I just looked at our scorecard last week. I think we have about 40 individuals in that program right now.
Okay, thank you.
And again, you have to have that designation.
Yes,
in
of
order
course.
to enter the program.
Yeah.
So, Mr. Chairman, one more. I think I forgot the obvious question was, does the jail tax provide any support to those county diversion programs?
No.
Okay, thanks.
Please.
I think that might be my last slide. Let me, recidivism. That's probably important. So we do look at recidivism every single year. And what we do is we take the previous fiscal year's cohort, so everyone who completed diversion in the previous fiscal year, and we run that against information we get from DPS around new arrests, new submittals to our office. We also look at new entries into DOC. That number is super small, and so I just was looking at submittals and arrests for the purpose of this conversation. So what those charts are showing is for individuals who have successfully completed diversion, you have about an average of 8%, 5%, almost 6% for a new submittal, right? So you have it broken down year over year for 21, 22, and 23. But it's about almost 6% average. We will get a new submittal. Arrests, obviously, that average is higher because not every arrest results in a submittal to our office. You do see an increase in year 2, right? So it almost doubles. And so that's those who successfully completed will have a new submittal within 2 years. Same thing with new arrests. So that's that 2-year mark. And then we look at it at 3 years, right? So it's almost, incremental same kind of percentage increase year over year. We stop at 3 years. We don't, follow you for the rest of time, but we look at 3 years, and then, we'll bring new cohorts in to the mix. So pretty good numbers, right, in reducing contact with the criminal justice system. So, yeah, I thought it was pretty good. Not that I have any control or can take credit for any of it. I have a wonderful team.
Well, we're going to give you the credit.
Oh, thank you, sir. I appreciate it.
Any additional questions from the committee?
Chris, I just have one. It's a follow-up to what Dawn was talking about. In terms of the drug testing, are they're also paying for that, but because most are on access, that's covered?
So access, as of right this minute, does not cover drug screens, right? So while we have the ARPA funding, we are offsetting the cost of drug screens. So we pay for them, and so for the felony diversion program, that number of like 760 folks that are enrolled, about 80% of them are going to be doing drug screens. Just that's the risk level. We have one group, one track of treatment that doesn't require a drug screen. That's a very low level risk. Who don't have a history of drug use or have significant history of sobriety, then they can go into that track where they're not required to do a drug screen.
I have
Please,
another one.
Chief.
And if you don't or can't answer this question, just say so.
Wonderful.
I see the numbers that go back pretty much this year on some of the previous slides. Because we're trying to figure out funding long-term and see the fluctuations. My question is this: how much of the diversion program is subject to political influence? So, for example, what if we have a different Maricopa County attorney that says, either way, I want to be harder on crime or I want to be softer on crime? Smarter on crime. Okay, whatever that is. So pretty much the information here is back this fiscal year, it looks like, around that time period. How much is influenced by political risk to this type of a program? And again, I'm not trying to get you in trouble.
I
so,
appreciate that.
Okay.
This is being recorded too, right? Okay. So I will say the numbers, I can give you the last 3 fiscal year numbers, and the ones I showed you today are very similar to 2 years ago. We had a really high increase in diversion cases last fiscal year, so not this closest last one, but the one before. And it seems like an anomaly. It doesn't really make sense. There's no real reason why we have such a huge increase. So that gives some historical context, right, through at least one other county attorney. Diversion is at the discretion of the county attorney. So whomever sits in that seat can make whatever decisions they feel is appropriate. So maybe. I don't.
It is subject to. I could come to that conclusion myself.
Yeah, I mean, it's at their discretion. One, if diversion even occurs, right? They don't have to do diversion. Statute leaves that to the county attorney's discretion. And then what programs continue or don't continue is up to the county attorney.
Okay, thank you.
So,
Thank you.
sorry, Christy, can I ask just one follow-up question?
Of course.
So when we're talking about the fluctuations in the participation, do you think that that's tied directly to the ARPA offsets?
I don't. So the leading cause for people to be unsuccessful is non-enrollment. No one pays for enrollment, right? In the assessment that comes along with that, we are covering the cost. And so that's really getting to the provider and following up on that intake appointment. And so I don't think that is. And then the second reason for unsuccessful is drug screen noncompliance. If we can, make some headway in those 2 spaces, you see, some difference in the numbers. And we are working with the providers to increase that enrollment percentage. We have, like I said, we've seen that level off, and we don't have such flexibility in it like we used to. So whatever we're doing is helping it keep steady. Now we just got to ramp it up a little bit.
So in those efforts, we know from other experience that people leaving jail don't necessarily make it to a variety of appointments, whether they're health appointments or to probation. And what we've seen is that there are ways to rectify that. And part of that is having navigators or people in the behavioral health system that help get people to that first assessment. So is that being looked at, or is that something that we can consider making a recommendation on?
I'm open to recommendations to helping folks be successful in these programs. So what we are just starting to do, I'm having a meeting with the defense bar tomorrow to talk through our providers' engagement with folks who are in custody. Like I said, that number is small, but it's still big enough that it could make a difference. And so we are going to begin a process. We have a provider that's housed at South Court Tower, and we're going to build a process where that individual is going to meet with those that are in custody and offered diversion, talk to them about what diversion means, like what is that, and then give them information for their intake. Hopefully to make that connection. That's about as best of a connection as I can make with the tools I have today. What we do know while we're replicating that for in custody is folks who have cases at South Court Tower and offer diversion that meet with this individual, this provider, are way more successful in enrollment. In like 80% plus enrollment success because they talk to this individual. Maybe she has magic powers, I'm not sure, but whatever happens there is working for that group, and so we're going to do that for in-custody folks and hopefully see an increase in that enrollment as well.
Is there a way to look at a way to take that same service to people that are not in custody? Because what it seems like you're seeing, that we've seen across other areas, is that it's about information and connection.
Right.
And that connection with a person and that information, we call that like a warm handoff or whatever, that could also be beneficial for people that are out of custody.
Yeah.
Is there a thought about how to?
We've had several discussions with the defense bar on how to improve people meeting in person with that provider at South Court Tower. So 90+% of diversion cases are heard in the South Court Tower. And we're brainstorming ways to you need to go talk to this person. There's a list of barriers to that. I got to get back to work. I got to get back to pick up my child. There's a whole range of reasons why they can't stay and sit at court and wait to meet with her. So, but we continued to brainstorm with defense of how can you help us get your client to go talk to this individual, short of making it mandatory to go to diversion, right? So we don't want to put another roadblock into someone getting the help that they need. So we're trying not to do that. I don't want to do that. Our offices want to do that, but we're trying to get as many people to meet with her as possible.
Thank you.
Thank you.
A lot of good information and some great questions.
Okay, yes, I appreciate it. I'll get more specific data on the things that we talked about today, too. Thank you so much.
We will move to agenda item number 6, a presentation from Blair Bryant of the National Association of Counties.
Good afternoon, everybody. Can you hear me okay?
Yes.
Awesome. Well, it is great to be speaking with you guys today. And I think what you'll find is that what I'm going to cover really dovetails nicely with the first presentation. I was just listening in a little bit. So I am here first, I work as the Health Policy Director at the National Association of Counties on our government affairs team. So my role is to really track federal legislation and regulatory changes that impact county priorities in the area of health. And this issue kind of sits at the intersection between health and justice, and is really a top priority for NACO and for counties broadly. So I'll start by saying for the first time, Medicaid is being authorized to cover some health services for individuals in the period of time before they're released from incarceration. Historically, although people who are incarcerated may be eligible and enrolled in Medicaid, the program's longstanding inmate exclusion policy really prevented coverage of services for people who are incarcerated, with the exception of inpatient hospital stays. Recent policy changes aim to promote smoother transitions at the reentry point, establish connections with community-based providers at release, and promote access to needed care and support. And I don't have to tell you guys that ensuring individuals have Medicaid coverage and really connections to care upon reentry has the potential to improve a range of health and public safety outcomes, which include mortality, unnecessary emergency room visits, hospitalizations, and of course, rates of reincarceration. So we can go to the next slide. Thank you. So these policy changes are groundbreaking and ongoing. They've been taking place through statutory changes made by Congress and administrative changes made by the Centers for Medicare and Medicaid Services, or CMS, via what's known as Medicaid 1115 demonstration waivers. These waivers are a tool through which CMS can waive provisions of federal law for individual states, provided that waiver serves the objectives of the Medicaid program. So I'll go over really two leading opportunities to revise the inmate exclusion policy under Medicaid that we are tracking and that states can take advantage of right now. And I wanted to start with just kind of a comparison and contrast of these two policies because they're often misconstrued and confused for one another. So the first opportunity is an opportunity that was made possible by the 2023 Consolidated Appropriations Act, and it's a juvenile reentry provision. This provision would apply to youth under the age of 21 and would provide a discrete set of services covered at the point of reentry. It is a statutory mandate, so meaning this is law, this is not an option, and it is a state requirement under Medicaid that starts January 1st, 2025, so in just a few short months. So again, this is a statutory mandate, state requirement would apply to youth re-entering into their community, and CMS defines youth as anyone under the age of 21. The second opportunity are, of course, the Medicaid 1115 reentry waivers. We saw the first approval of a waiver of this sort last year, with California being the first state to get this approval. And what it does is it applies to anyone incarcerated in state prisons, jails, as well as youth correction facilities. And it allows a minimum set of services to be provided ahead of an individual's transition from a carceral setting. These waivers, as I mentioned, are demonstration only, so they have a 5-year window from the time of approval. Once your waiver is approved, you have 5 years to kind of get this up and running under your Medicaid program, and then you have to reapply after demonstrating that this particular service was effective in meeting the objectives of the Medicaid program. And this is a state option, so not every state will be mandated to implement these services, but again, a broader kind of sweep of populations impacted than just the provision being implemented in January. So both of these things are great in terms of their ability to amend the exclusionary policy and start the process of reconnection to care prior to release. They just impact different populations. One is a requirement, one is an option. So I'll dig a little bit deeper into these two policies. Next slide. So first, starting with the youth Medicaid reentry policy. So as I mentioned, this was made possible by last year's Consolidated Appropriations Act, and the effective date is January 1st of 2025. States must submit Medicaid and CHIP state plan amendments before this date, so indicating to CMS how you plan to implement this particular policy. I believe there will be some flexibility on that submission date too. In discussion with CMS, they didn't get their guidance out about this policy until about a month ago. So there will be some flexibility in states' ability to submit a state plan amendment outlining how they plan to implement this policy change. Again, the eligibility for this particular policy change is youth under the age of 21, which include former foster care children who are enrolled in Medicaid before or during incarceration. And then states can receive federal funding for services for eligible youth that are also awaiting trial. So this impacts pretrial detainees as well in the youth space. So what's required? First is screenings and diagnostic services. States must provide medical and dental screenings and diagnostic services within 30 days before an individual's release and no later than 1 week after release. In addition to screenings and diagnostics, targeted case management. So states must offer targeted case management services, which include referrals to other community-based care sources. Similar to Medicaid, CHIP must also include these services 30 days before the release of eligible youth. States can suspend or continue CHIP coverage during incarceration rather than terminate it. And CHIP coverage must be reassessed before the youth's release and maybe extended to youth awaiting trial. So for more information about this particular provision, you can use the QR code on your screen, but I also sent ahead some links to some of NACO's analyses talking about this policy change. Next slide. So going into the second policy change, and that's the 1115 demonstration waivers under Medicaid. What these waivers do, and remember, this is the option, the state option that states would apply to and get approval for. And what these waivers would do would create an amendment to the inmate exclusion policy that would allow incarcerated individuals to receive Medicaid health services at least 30 days before release. So counties can expand access to mental health and addiction services using this waiver, because you can allow individuals who are re-entering the community to be connected to those services prior to their release. Some of the required pre-release services include, but also don't preclude you from doing other services. This is just the minimum standard of services you have to provide under this demonstration waiver. So case management, medication-assisted treatment, and a 30-day supply of prescription medications upon release. States also who get approved for this demonstration waiver will receive enhanced federal funding for a Medicaid eligibility and redetermination systems reform. So if the state has a waiver that is approved, they will get enhanced FMAP for eligibility and redetermination systems reform that would hopefully make transitions like this easier on all the facilities involved, including the jails. So the eligibility criteria for states participating in this demonstration program are states that suspend rather than terminate Medicaid eligibility upon incarceration, and that is every state now, because according to the Consolidated Appropriations Act of 2024, every state must now suspend rather than terminate Medicaid eligibility upon arrest and incarceration. So state waiver applications should ensure that only allowable benefits are covered. CMS is very clear about what allowable benefits are. Like I said, you kind of have a set list of mandatory minimum benefits, and then you can kind of expand from there, but there are guidelines as to what benefits can be provided. The benefits must be budget neutral, and then states must engage individuals with lived experience and include a detailed implementation plan as well as a reinvestment plan for federal matching dollars. So, how will you reinvest those federal dollars into programs and services? So counties obviously can help design and implement these demonstrations, but the state Medicaid office is who actually submits the application. NACO encourages counties to work with their state Medicaid offices and specifically county jails because we have seen that some of the states are leaving out jails from these demonstration applications, meaning that their applications to CMS only address prisons and don't address jails, which is not what we want. So making sure that counties are at the table so that jails can be included in these demonstrations, because we hold the highest amount of individuals who are returning to their community and at risk for recidivating, which is what we're hoping to avoid with this demonstration project. Next slide. So just a quick overview of states that have been approved for these demonstration waivers. So right now there's a total of 11 states that have approved waivers. So this includes California, which was the first, Washington, Oregon, Utah, New Mexico, Montana, Illinois, Kentucky, Vermont, Massachusetts, and New Hampshire. There are 13 states with pending waivers. They're in the lighter blue. You'll see that Arizona, which I've circled, has a pending waiver. Other states that have pending waivers are Colorado, Arkansas, North Carolina, West Virginia, Pennsylvania, Maryland, New Jersey, New York, North Carolina, again, Connecticut, Rhode Island, and Hawaii. And then there are 3 states that have indicated that they're working on developing waivers, and that is Maine, Louisiana, and Michigan. So digging a little deeper into what was submitted by Arizona. So the Arizona waiver was drafted and submitted by the Arizona Healthcare Cost Containment System, which runs your Medicaid program. And the waiver requests included a number of reentry services that fall in the lines of the guidance for CMS. So that was one-to-one case management and educational services for stable housing. These are specifically for individuals reentering. Assistance with housing applications, utility setup, and reinstatement. Integrated discharge and care plan for medical, behavioral health, and social needs, as well as linkage with health providers and peer supports for continuity of care. And these are in addition to kind of the standard set of services that were included, that should be included in these waivers. And so who will it cover? It will cover reentry services for Medicaid eligible individuals with serious health conditions at high risk of homelessness upon release. The services will begin 30 days prior to release to ensure care coordination and community linkages. And then AHCCC has implemented some successful discharge coordination programs that they're hoping that this demonstration would work with in order to prove outcomes across the continuum. So that's a little bit about the Arizona waiver. I'm sure you guys have seen it. If not, I can provide a link to the full rundown of the waiver. It's on CMS's website and currently has a status of pending. So with that, I will pause, and my information is on this slide if you have any questions for me, but I'm happy to take questions now as well.
So,
Thank you. We've got a question to my left.
Sorry, 2 questions. First of all, is there anything within it, and I can certainly review it when you send it out, that NACO is addressing data sharing between providers in the community and jails and or prisons?
So Specific to the Arizona waiver, I did not see that in there. I can take a look at it. I haven't seen anything in waiver applications, particularly that talk about data sharing, but there's an opportunity for states to elaborate that when they submit CMS their implementation plan. So we're taking a look at California's implementation plan. In fact, in 2 weeks, we have a webinar where they walk through how they're implementing this demonstration waiver, where they do specifically talk about data sharing agreements between providers and jails. So it's not something that's required for the submission of your application, which why it may not be in Arizona's application that they submitted, but it is something that you can expound upon when you submit your implementation plan.
Okay. And then the second thing is the requirement is 30 days before release. But as you know, in jails, the vast majority of people are in pretrial status, and it isn't always clear when people are going to get
Yes.
released. So this is not just covering people that are sentenced, correct? It also includes people that are in pretrial status, that are detainees.
Yes, that is the beauty of CMS's guidance in the way that they allowed states to submit their applications. States have the flexibility to cover pretrial detainees as well as individuals who have been sentenced and are reentering after serving time. So California, again, is another example of a state that is covering pretrial detainees under this demonstration waiver as well.
Thank you.
Other questions?
I do.
Chief Tobin?
This to Danny or whatever. Connect the dots for me on this presentation and the relevance to our issues. Is this about funding for medical services in the jails? Is that why we're hearing about this? I'm just trying to connect
Danny?
the presentation to what it is that we're trying to figure out.
Yeah, so this came up a little bit last week. Dr. Nagel brought up the kind of communication between, when people are getting out of this criminal justice system and making sure that they have some level of support from a healthcare and community perspective so that they don't go back. Without knowing exactly what the waiver is going to look like finally and all of those things, it's hard to put a number on what this means, but it would, I believe, decrease our medical costs for those that are covered by access. But without knowing the exact population and what's going to be, yeah.
Well, and if I could add, it's a significant cost that 30 days worth of medication would be provided by community providers rather than by correctional health services, which becomes part of the detention fund. So that's number one. That's a very direct cost. The second thing is by medication-assisted treatment, which is what's provided for people that have an opioid use disorder. That is very significant in that it means that people are linked. They start their medication-assisted treatment, whether that's methadone or whatever, and then they receive that treatment when they go out. There's a firmer, so that assists with good health outcomes, but also in reducing recidivism. And then the third thing is these programs are known. The research has shown that they reduce recidivism. So it's going to decrease the population. So what we want to see is as jails are constructed, they're being constructed based on a current population or population estimate, and we don't want to see that population increasing in ways that we could see the recidivism reduced so we don't have a bigger jail population. Does that make sense? Yeah.
And just to step in on it for a moment, that's also true for the youth. So we've been talking mainly about the adults, but juvenile detention has the same issue that the jail does. So you would actually see some of the cost savings there. I do have a question, Blair. On the youth Medicaid reentry, it says youth under 21. Would that include youth that are held in adult jails?
Great question. And yes, it does include youth that are held in adult detention. That was a question that was raised in the guidance because CMS has this cutoff of 21 just based on their standards. Everyone wanted to know if they could use this provision in adult correctional facilities, and they responded with yes in their guidance. So that's great news for us.
Blair, thank you.
Thank you.
We will move to agenda item number 7, presentation on community health trends from 2 of our local doctors. We'll invite Dr. Jeffrey Johnston and Dr. Rebecca Sonnenschein to join us. Welcome.
Good afternoon, Chairman and members of the committee. I am Dr. Rebecca Sonnenschein. Good to see you. The Chief Medical Officer for Maricopa County Public Health, and this is Dr. Johnston, the Executive Director and the Chief Medical Examiner. And we just wanted to take a little bit of time today to talk to you about the issues surrounding substance use and mental health and some other things in the community that affect the jail population. If I could have the next slide, please. Oh, I got it. Sorry. Now I got it. All right. Sorry. So first, we wanted to start by just sort of sharing why Public Health and the Office of the Medical Examiner would be here presenting to you today. Public health really has 3 foundational roles, including assessment, policy development, and assurance. And the ways that we execute these roles are by reporting on community health status overall, including the causes of death and health disparities via the Community Health Needs Assessment and other specific health-related data reports. We prevent, track, investigate, and respond to both infectious and non-infectious diseases in the community, and we do that through both partnerships and direct services. And we work with internal and external partners to address public health or population health concerns such as substance use, mental health, family health, and extreme heat. In our role today, we are supporting correctional health services and the jails with analyzing data surrounding the community and the jail population. And now I'll pass it over to Dr. Johnston.
Thanks. Good afternoon, everybody. So I thought I'd just give you some basics about the medical examiner. Sometimes there's misconceptions about what we do, what we don't do. We're a statutorily mandated county agency. We perform medical death investigations. So it's an entirely medical operation. We're looking at deaths that are non-natural, so the suspected accidents, suicides, homicides throughout the county, all the cities and towns. We look at natural deaths if they're sudden and unexplained, so particularly young individuals who don't really have a health condition that might explain their death, folks that are not under the current care of a healthcare provider, and deaths while people are in custody, so while we're here, suspected to be caused by an unreported or undiagnosed public health condition. So for COVID, if they went to the hospital and died, that's diagnosed. Those don't become our cases. But if they die out in their homes and they didn't make it to the hospital, to a healthcare provider, then we would evaluate those to make sure we've got good surveillance of these things that are happening in the community. And if there are deaths that involve unidentifiable bodies, because we want to make sure we positively identify the person first to understand who they were. So what we're doing is determining the medical cause and the medical manner of death for death certification. This closes that vital loop that starts with a birth certificate. And we try to answer anticipated questions that the public may have about the death. And really our goal is to try to help others put us out of business, right? So to understand what our mortality risks are in the community so we can develop, policies and interventions that reduce morbidity and mortality in the community at large. Our office is accredited by the National Association of Medical Examiners, follow forensic pathology medical practice standards, and we do medically investigate all in-custody deaths in the county. But one thing we don't do is perform audits or assessments of standard of care practice. So we don't have expertise in that realm. One of the reasons we were asked to speak with you is a recent Arizona Republic story. The article notes that Federal Department of Justice changed how it collects national statistics. So unfortunately, we don't have any way to compare what we're doing locally to the national level. One of the sources that they quote in there notes that one of the big problems is there's not the denominator. We really need rates, right? So we need to know what the jail population counts are because 30 deaths in a jail that's got 500 people daily is a lot different than one that has 50. The article, since there is this difference, and the last year for these statistics was 2019, and the county's rates were just below the national average. Of course, some things have happened since 2019 that we have all been through that suggest that maybe things might change. So the article fills this gap by comparing jail death rates in Maricopa County to those in Los Angeles County, California, Cook County, Illinois, New York City's Riker Island Jail, and Harris County, Texas, and notes that all of them have about half of the jail death rate that Maricopa County does in either 2022 or 2023. My sense of this is that we just have to really be careful about comparing quality of care in jails among these 5 systems, kind of just based on the fact that they all serve large populations. And the thing that first comes to mind is that we really need to understand the underlying health risks of the community that feeds into those jail systems potentially. So for example, if you compare my office's 2021 annual report to LA County Medical Examiner's annual report, there's a lot of differences in our general populations that might feed into jails. Our methamphetamine-related death rate is 104% higher than theirs is. Our heat-related deaths, so those hyperthermia deaths, is 1,400% higher. Our suicide death rate is 100% higher, accidental death rate 80% higher, and drug-related accidental death rate 39% higher. So we do have a comparator. So Pima County, when you look at our numbers in 2023, they're very similar on all of these metrics. So we really have this very similar general population. And the article notes that the jail death rates are similar, which kind of bolsters this idea that we really need to think about the underlying community that's coming into the jails. So next is kind of taking a general look at just substance use disorder as an example, since that was highlighted in the article. So at the state level, among the states noted, we excluded New York in this, we've got the highest substance use disorder prevalence. If you drill down to the county level in 2020 and 2021, we've got the highest fatal overdose rates as well. And as you can see, a lot higher than LA County and Harris County.
So Dr. Johnston mentioned how important it is to talk about the particular population that the jails serve. And we just wanted to draw a picture of how the health status of the inmate population coming into the jails differs from Maricopa County as a whole. So substance use, and a lot of this I'm sure you already know, but substance use disorders and mental illness are significant health issues both nationally in Maricopa County. And since substance use, possession, and sale of drugs are all crimes, there is a much higher proportion of people with substance use in jail than in the general community. Mental illness does frequently co-occur with substance use. Two often go together. And both substance use and mental illness are both associated with increased mortality or risk of dying, putting the jail population at a higher risk of death than the community members overall. Thanks. So we took a look at correctional health's numbers for the inmate population when they are entering jail. So this is at intake, and they have a couple of flags that they use to identify people who are going to need specific services while they're in custody. And the 2 flags that we're going to talk about are one that's called substance-related disorder, and the other is mental health. So if they have a chronic mental health condition combined with being diagnosed with serious mental illness, which is an actual access classification. With the exception of the SMI piece, both the mental health and the substance-related disorder are self-identified or self-reported. So you can imagine there's a stigma associated with both substance use disorder and mental health. So I would consider these numbers to be underestimates of the true value, because not everybody is going to directly, when they're entering jail, want to admit that they have either a mental health and or a substance use disorder. When you look at these trends over time, these are the percentages of the population by year that have each of these flags. And so looking at the blue line, which is substance-related disorder, you can see in 2019, prior to the pandemic, that's how public health lives before and after pandemic, sorry, we were at 24.1% had a substance-related disorder. And then you can see in 2023, that number goes up to 45.5, which is an 89% increase. It's very high. Looking preliminarily at 2024, it is also going up. That orange line is the mental health at intake, again, combining SMI and mental health, and that increase is 48% from 2019 to 2023. So you can see the population entering jail really changes. Oh, let's go the other way. All right, so we looked at a second parameter, which is the percent of jail inmates with a mental health flag, so that's what you already saw, or SMI, and then we combined it with those who were actually treated for mental health during custody. And that sort of helps with that concept that those were an underestimate. So if someone required mental health care during custody, they probably had a mental health condition before they came in, and this is combining all of theirs. And I think this probably provides the most accurate view over time or estimate of folks who actually have a mental health issue. And you can see that it went from 47.4% in 2019 up to 62.8% in 2023, which is a 32% increase. Go ahead.
Mr. Chairman, okay, one quick question. Have any of the protocols for identifying these conditions at intake changed over time that might account for changes in numbers?
So, Director Struble, do you want to answer that question?
Come on up, come on up. We have another chair we can pull up. Do you need the question to be repeated, or did you get it?
No, I think I can answer it,
please.
Chairman and members of the committee. So our medical protocols change as the population changes, or they stay consistent with community guidelines. So our medical director and our national accreditation also guide us in those protocols. So, for example, our opioid withdrawal protocols, our intake screenings have changed even just in the last 2 to 3 years to identify, and change our response as we've learned and understood how to respond to the substance use disorders and in the severity that we're seeing coming in. So the answer is yes, we do change those criteria as the patient population changes. Whether it's affecting these numbers specifically, we could look at, the last 3 years of when we changed those protocols. In particular, in the last year would be when we, for example, changed when we initiated withdrawal protocols. We used to gather information as people came in, assessed that, and then got them to care quickly. Now we're able to actually implement withdrawal protocols right at the intake facility that you've been through.
So if I could ask a question, Director Struble, it is very possible that because there's increased surveillance around opioids particularly, and because of medication-assisted treatment being offered, that could have an impact on the increased number of people being identified with substance use disorder, potentially, maybe. However, so there's another thing to go on. I don't know, but I'm imagining that there hasn't been dramatic changes in the way that mental health flags are set. So that increase would more likely be because there is truly an increase in the number of people requesting services, identified needing services. Is that?
Yes, Mr. Chairman and Dr. Nogel, that's absolutely correct. And I also think that as we've been able to get the message out to the community that we have MAT treatment available in the jails, people are more likely to report their substance use and abuse at intake, so we can initiate that right away. I think that's been a big part of it, and we want to get those services to them so they're not suffering through that withdrawal.
Mr. Chairman, can I ask one more? Just while I got you here. In the last 3 slides, we've used the term substance-related disorder and substance use disorder. Is there a difference there, or is that capturing a different thought?
So we differentiate different substance misuse basically at the time of intake the best we can. So for example, medically speaking, we have different withdrawal protocols that we follow based on the type of misuse that's being reported. So whether it's alcohol, benzodiazepines, or opioids, our medical providers will then steer the withdrawal to that. In terms of the terminology within the slide, I'm not sure. We try to look at any of the substance misuse really as then whether it's a disorder that we need to pursue treating, and we err on side of caution on that.
I'll just add that the actual name of the flag that they use in the analysis is substance-related disorder. That's just how they identify the flag. It is very similar to substance use disorder, which is a general medical terminology for all disorders related to substance use. So I would consider them comparable.
I'm going to ask another one of my crazy questions because I don't know that much about all this. But when I see these numbers and I'm trying to figure out, what we're trying to do here, there's got to be this. You see the same people a lot. You see them once, you see them again. We just heard a little bit about the county attorney, what it takes to prosecute somebody, and different programs. How much of this is it the same people? And I'm imagine it's a lot. So the next question would be, I don't think you have the answer, is what are we doing wrong, and how do we fix it, other than continuing to cycle people through the jail system time after time, whether it's mental health issues or substance use disorders? So if you had your magic wand, because we're trying to, I guess from my perspective, is what does the next 25 years look like, right? I mean, that's where we are. So this seems to be a pretty significant reason why we have a lot of people in our jail system. What's the better way to go about that than what we're doing now? I get it. I totally respect your staff. We spend a lot of time with them. We fix them up. We get them stabilized, and maybe they get out, and then I'm sure you see Mr. Tobin over and over again. So, I don't know. I'm just trying to get my hands around it, if you wouldn't mind.
You're absolutely correct. We do see patients come back and again. The role for correctional health services is to get them the care that we can and link them to services. That's what we feel is our role in the key that we can help set them up for success once they leave our facility. Getting them to access to medical care, continued treatment, mental health support, and then I think it's all of these other departments they're doing all of this great work, the diversion efforts, but I think if I knew the answer, I would, I'd be a wealthy woman, but I think it's the combined efforts to everybody on these linkage to services and supporting individuals as they come in where we meet them. So at Correctional Health, we really do focus on an individual patient's needs, whether it's their medical, mental health, dental, or community needs, and then identify them the best we can right as soon as they are booked, and help link them to then the professionals and the care that they can receive once they leave our facility.
Let me just add one thing that, that hasn't been talked about directly, and that is very difficult because the jail detention fund doesn't address this, and that's the lack of housing. And so the research shows that people who are homeless, a great percentage of them, an incident in being arrested, this is nationally, precedes their homelessness. So once people are then arrested, they lose housing, now they have a record, and now that research was done back in the early 2000s, maybe 2010. And now that was before we had a huge housing crisis that we have nationally and we have locally. So that's something that when we turn to the recommendations being made, it's one of the things that we can look at. The jail detention fund can't solve that, but these linkages and encouraging the thing that's happening with the waiver with Medicaid at least starts to address that. So I just wanted to add that.
Please.
Thank you. Thank you both, and I agree with absolutely everything that's been said. I also want to highlight that the one evidence-based treatment for people who do have substance use disorder is medication-assisted treatment. And so I really want to compliment Director Struble and her team for systematizing medication-assisted therapy for opioid use disorder in the jails. I really believe that it's evidence-based, and that is the way that we are going to reduce not only people who have substance use disorder, but opioid-associated deaths. And as you've seen in the national numbers, I hope you've seen it in the news, there is already a decline. No one really agrees on why that is, but I do think it's a combination of increased access to treatment as well as harm reduction, which they are also implementing in the jail system, including naloxone and other things such as that. So I do think that Correctional Health Services is addressing this with the most evidence-based strategies and everything that can be done to offer people with substance use disorder access to MAT, and then connection to continued MAT when they leave the jails, that is what's going to keep recidivism down, in my professional opinion.
And that would be the case for the substance use disorders, not necessarily also the mental health issues, right? There's something connected there as well.
I would say if there's co-occurring, both would be addressed. And a lot of times people with mental health issues use substance abuse to mask what the real problem is. So it would really be both.
Marissa, did you, please?
So harm reduction, prevention, all of these issues, I would say what I see is the importance and the investment in the prevention so that our providers at the jail system are not getting bottlenecked with these populations and that they're not coming back. So the jail excess tax says on there that we also need to be investing in harm reduction and prevention and health services before they get arrested, before they go into the criminal justice system. And there's so much focus about once they're already there, but we could be saving a lot of money at the front end, building more bigger jails, but we also have to note that we have to consider as well in the recommendations because they're gonna get bottlenecked if we don't also just address the elephant in the room. And that's kind of what I wanted to address with that prevention piece and the substance abuse piece.
Thank you. Please.
That is such an important point. Thank you so much for highlighting it. And I do want to emphasize that the county does receive opioid settlement funds for exactly this purpose. We work very closely with Correctional Health Services as we are investing heavily in medical assisted therapy in the jails. We're also investing in the community, both through treatment, prevention at the youth and adult level, as well as harm reduction. So we're trying to take it from every angle from a public health effort so that you're not seeing all of these people in jails.
Barbara?
I couldn't have said it better. I do think, though, going back, the linkages, because correctional health has done a phenomenal job with Matt. When people are released, let's say they come to probation, getting the linkage that we need with the community health providers, the behavioral health, it has been very difficult. And I'm hoping that that's one piece that we can really address. It really is the handshake that's missing. And there's lots of reasons for that, and some of it is data linkages so that we know what's appropriately a person who has an SMI label and able to get them into appropriate integrated healthcare.
Please continue.
So the next slide just compares the overall death rate in the county, which has been higher from 2020 to 2022 than the death rate in the county jails. Again, kind of just giving you a sense of the greater community that funnels into the jails. But when you do dig down into the overdose death rate, it is higher than what we see in the general county and, mirrors the increasing trend we're seeing with substance use disorder entering the jails for all the reasons Dr. Sunshine was talking about. Similarly, so that's the overdose. Apologies. And then similarly with the suicide death rate, it's also higher in the jails than in the county, but again, sort of mirroring this trend of increasing along with that increasing trend of folks with mental health disorders entering the jail. So the summary is really just care and death rates in jails, but comparing between different jurisdictions. It really is disappointing that we don't have national comparators anymore, particularly we can compare what has happened in communities across the country with the pandemic and all the halo effects around it. When we do compare death rates in Maricopa County with Pima County jails, they are similar. This makes sense that we've got similar communities that are coming into the jails. And I think it gives us some pause about putting all the blame on the Maricopa County jail to solve all of these problems. And really, if we're going to interpret trends in jail deaths, it's really helpful for us to look at those health trends of the folks that are coming into the jails.
Very helpful. Thank you.
Okay, any questions or comments from the committee? To the three of you, thank you. Agenda number 8, we welcome back Public Sector Performance Associate team members, please. I think that is Monica and Sam, is that right?
That's correct.
Good afternoon, and a couple others. Good afternoon, Mr. Chairman and committee members. I will say before I start that I am in a hurricane watch at the moment, and we have contingency plans for carrying through the presentation if my power happens to go down. We've had a couple of flickers throughout the day, but it's been holding steady the last few minutes.
So Dan, we had this question whether Monica should come here for this meeting. Maybe we should have said yes, but I think we'll see on October 10th. But
I think the airports are closed, so she might have dodged a bullet.
The airport is
actually.
Excuse the interruption. Continue.
The airport has been closed since I believe yesterday. Thank you. Well, good afternoon again, everybody. It's a pleasure for me and for my team to be here. We're very happy to present the results of our work. with me here today, presenting pieces of this session are Sam Yin and Stu Griffel. Other members of the team are standing by, I think, connected via Zoom, via teammate, apologies. My understanding is that in front of you, you have our first part of the report.
Yes.
Okay, very good, very good. Well, the first part of the first page of that report summarizes the project objectives, which we grouped into 3 areas. Number 1 was the presentation of a full profile of each of the four departments that received detention fund monies. That is Correctional Health Services, the Sheriff's Office, the Juvenile Probation Department, and the Adult Probation Department. That profile includes the in-depth description of the programs and services that are funded by detention fund monies, a determination as to whether those services and programs are supported by mandates, which are federal, state law, or court rulings. And lastly, it includes a compilation and analysis of existing performance measures associated with those programs that receive detention funds. The second objective is a value analysis of services and programs, which includes an assessment of the expenditures, increases and decreases over time of those services. Second, an analysis of significant cost drivers. And lastly, a report on any observed opportunities for improving efficiency and effectiveness. And lastly, objective number 3 is an evaluation of current trends and future needs, including an assessment of cost to meet the mandates now and in the future, a review of information about recidivism, an analysis of factors impacting funding future, and lastly, research of public safety funding mechanisms in Arizona and counties in other Western states. So meeting these objectives requires significant effort, as you can imagine. Our team covered a lot of ground and reviewed a lot of information and a lot of data. And we could not have done this alone. And I want to point this out because the leaders and staff of the 4 agencies that we evaluated, as well as staff from the Budget and Finance Office, have been true partners. And we want to express our appreciation for the time and effort that they put into providing the information that we needed in order to fulfill our objectives. The departments collaborated with us along the way, and they reviewed the drafts prior to their release to ensure that they were completely accurate. And this report incorporates their comment. Special thanks also to Danny and Paige for their continued support. Today, we're presenting to you 4 of the 8 sections that this report will include. On October 8, we will present the remainder sessions and answer any questions that you may have on the piece that you are reviewing today or that you have received and the entire report. We will do a final quality check and make any adjustments needed before we move on to the final version. So now going back to the draft, we thought what we would do is to do an overview, kind of go by the pages and point out to you the items that are important. Each department profile has 4 distinct pieces. First, there is a overview of the department and the services that are funded with detention fund. Then we have analysis of the mandates. And lastly, we have cost analysis. So those are the 3 pieces that you will see in each of the profiles for the 4 departments. So at this point, I am going to pass it on to Sam Yin, my colleague Sam Yin, who will be covering for us the juvenile probation and the adult probation departments.
Good afternoon. Can you guys hear me clearly?
Yes.
Awesome. Hey, good afternoon. I'll start off with giving the overview on the juvenile and adult probations. They're very similar in nature, but we'll start with juvenile. The Juvenile Probation Department focuses on minimizing the use of secure detention so that it minimizes the chances of the youth to go through the formal judicial process in the criminal courts. Both mandated and non-mandated services and collaboration with the community and other programs contribute to the overall success of the juvenile probation department. Now, as far as the juvenile probation department goes for Maricopa County, everything is trending upward with population growth, but I say that with a grain of salt in that the numbers are low to begin with. I won't go through every single detail in the report that you have before you, but I'll go through the main highlights. With the exception of a few minor services, the juvenile probation department and all their services are mandated. They run or they administer one juvenile detention center. So unlike the adult probation department, they have a detention component as well. Initial contact with the juvenile justice system for the youth occurs usually when they have contact with law enforcement, who then submits a report alleging some sort of a delinquent act. Law enforcement may end up releasing the youth initially, or they may detain them. In any case, there's a referral that's sent to the juvenile probation department. In fiscal year 2023, the number of unduplicated youths referred to the department was roughly 6,395. That compared to the 8,337 from 2019 is a 16% decrease in overall referrals. Now, there is an option to have diversion, and I know you guys have already heard from the previous speakers a lot of related topics, so I'll go over it real briefly. Diversion just allows them to avoid the unnecessary formal court proceedings, and it also keeps it off of their record. The department has been gradually achieving higher and higher rates of success because they do measure their success rates. Diversion completion rates went from 86% to 93% between 2019 and 2023. Another outcome can also be detention. The youths are usually detained if there's a need for either the juvenile or the public's protection, and or to ensure that they do appear in court. Detention as a whole in the last 5 years has trended downward. It went from about 2,600-ish in 2019 down to about 1,700 in 2023, which is about a 35% decrease overall. And I caveat this overall because there are anomalies that you'll see in the graph that we put into the report. And I just want to caution you that these anomalies occur because of the unprecedented COVID-19 years that we experience. Probation is the most common outcome for youths who are adjudicated through the courts. There are two types of probation, standard and intensive. Overall, the number of youths on standard probation and intensive probation has seen a downward trend. And if we compare it back to 2019, it's roughly about a 43% decrease in numbers. Now, the average length of stay, though, has trended upward, and these are where it starts to correlate with costs. So from 2019 to today, it's kind of trended upward from about 24 days on average length of stay to about 29 days. And predominantly has been driven by higher risk juveniles because of policy changes. So the ones that they do have detained are more serious offenders. Juvenile probation, like I said before, does measure recidivism, and they track new referrals or reoffenses regardless of whether they're charged or not. And the method of measurement, it's very standard in the sense that they do it within 365 days following the completion of either probation or diversion. So in 2023, approximately 87% of youths who went through diversion did not get rearrested. Similarly, about 79% of those who completed their probation were also not rearrested. As we analyze the mandates for juvenile probation, there's two overarching laws that support these services. And I know you guys have heard this before, but just as a reminder, the first one really is the state of Arizona's revised statute Title 8 regarding child safety. And the second one is the Arizona Code of Judicial Administration, specifically 6-311. It requires the department to follow probation standards and detention standards. When we move into the cost analysis portion of our report, we see that in 2023, juvenile probation did expend a total of about $39 million of the detention fund monies. And if you look at the table that we have provided to you, you'll see how it's broken down. The detention services account for about 71% or a little over $28 million of the detention fund expenditures. Now, when we break that down further into per diem costs, this is according to data that we received from Juvenile Probation Department. The daily costs of diversion cases and getting processed with some community supervision is roughly $40 for fiscal year 2023. The daily cost of detention is $687 for the youth. So as you can see, probation is definitely a cost savings for the whole system itself, for government. Now I'm going to transition directly into adult probation. A lot of things are very similar. Maricopa County within Arizona has it serves the largest population of adults on probation. The probation is really just a period of supervision being served in the community as an alternative to incarceration. The primary goal for Maricopa County's Adult Probation Department really is to serve the court and to monitor the behavior, get them to change, and to manage the risk. Now, probation, just like the juvenile side, is considered to be a cost-effective approach within the criminal justice system. It allows them to remain in the community, avoid some of the financial burdens that the government would have to incur. Adult probation is really under the direct authority of the presiding judge of the Superior Court of Maricopa County. And through a series of programs, the departments, they focus on assisting those individuals on probation or pretrial supervision to successfully complete their conditions. As we look at the data shows that probation is far less expensive than incarceration. So in 2023, probation services per diem range from $5 for standard probation to about $30 for the prison to community reentry program, all of which is significantly lower than the per diem for incarceration, which we found out to be roughly $138. Again, this is all from data that's been given to us from the county's offices. As you look back in the last 4 years, detention fund expenditures have increased by about 17% for adult probation, going from about $40 million back in 2020 to about over $46 million in 2023. But as I had cautioned before, when looking at this data, this is primarily due to the COVID years, the increase in market-driven costs, inflation rates, the cost of goods and services, and I think we can all relate to that in our personal lives as well. So all of the adult probation services are funded with detention fund monies, are mandated by either the Arizona revised statutes or the Code of Criminal Administration. Everything is funded. There are some outside sources, but predominantly they do depend on that detention fund. The fund dollars are all destined to the mandated services. There are some services that are paid by detention funds. We will provide you all that document in the subsequent report. But I just want to clarify to you again that the stats and the graphs we provided, there were extra monies from the federal government in the form of the CARES Act and ARPA during that 2020 and 2021 year due to COVID. So as a result of that, you kind of see this sharp increase moving on past 2021. So just like the thesis in juvenile probation, the probation for adults is considered a cost-effective approach and avoids that financial burden to the government. At the end of 2023, the active probation population was roughly 25,623 people or adults. There are two main service areas for adults. One referred to as the court services. They conduct all that analysis and the preparations. The second one is really about supervision, which is what most of us are familiar with. Standard probation is the most common form of probation. However, standard probation, though it is the largest program in population, is not funded by the detention fund, except for some few specialty programs. Intensive probation is funded by the detention fund. That program, it ensures some appropriate supervision for those who are at high risk. In 2023, roughly 62% of the people on intensive probation, the one that's funded by the detention fund, did complete their probation program successfully. And within intensive probation, there was roughly 1,224 people by the end of 2023. So the total detention fund expenditures trend this way. In the last 4 years, for adult probation, detention fund expenditures have increased by about 17%. Now we're looking at 40 million from 2020 to about 46.9 million in 2023, but it's primarily due to inflation and that extra CARES money that was used to subsidize. According to the annual report that we obtained or were provided, probation services per diem range, like I said before, from $5 to $30 compared to the $138 if they were to be incarcerated. And really, that is the quickest overview I can give between the two probation departments. With that, I will pass it on to my partners for the correctional health portion.
Thank you, Sam. Can you guys hear me well?
Yes. And
Thank
let me
you.
just
And
pause for a minute.
Yes, yes.
Because we're going to a completely new section. Committee members, do you have any questions you wanted to ask on the first two sections before we move on? Okay. All right. Please proceed.
Thank you, Mr. Chairman. And I want to acknowledge also that my colleague Norma Barrios is also on the call in case there are any financial related questions developing. I think my camera has been going on and off, but it looks like the sound is working well. I will be covering now correctional health services, and we are on about page 27 of the document that you have in front of you. The mission of correctional health services is to provide constitutionally mandated medical, dental, and mental health services to all the individuals that are incarcerated in the 5 Maricopa County jails and that are booked at the Intake, Transfer, and Release Center. It's a 24/7 operation, and they serve approximately 7,000 inmates daily housed in the jails. And we'll now do an overview of the department services that is also on page 27. It all starts with health screenings. In 2023, CHS completed about 70,000 health screenings at the ITR. Moving on to the delivery of services, they are provided either on-site or off-site. Most of the services are provided on-site using the existing resources at the jails and the different clinics. Services are requested through a tool called Health Needs Requests, or HNRs. And in 2023, there was an average of 186 HNRs that were worked through by the correctional health team. Off-site care occurs when there is a need for a patient to visit with off-site specialists or to be transferred to a hospital for emergency services or for admission. If this occurs, detention personnel has to accompany that person to provide security during transportation and to provide around-the-clock observation if the inmate is admitted to the hospital. In 2023, a total of 303 emergency room visits occurred, which represents an average of about 8 per day. The next section goes through an explanation of the different healthcare services. I'm just going to zoom on a couple of them. Medication administration is a good one because it really speaks to the magnitude of the operation that CHS delivers. They have in 2023 a total cost of $5.4 million in medication, of which approximately $805,000, or about 15%, was for opioid treatment. A total of 35,000, almost 36,000 individuals received medication during that fiscal year. Psychiatric and mental services is a very important piece too. And in fact, about a third of the CHS personnel operate under psychiatric and mental health services. In this part of the operation, they provide psychotherapy programs which facilitate more effective self-regulation techniques for stress management. And the goal of CHS is to teach these patients coping skills that hopefully they can carry out after they are released to reduce the risk of reoffense. On page 31, let's touch on the opioid treatment program. A lot has been said over these last months about that. The number of patients in OTP and the number of patients enrolled almost quadrupled from 2021 to 2023, as you can see in that table at the top of page 31. This activity keeps correctional health personnel quite busy. They perform this procedure called clinical opioid withdrawal scale, or COWS. And in 2023, that was equivalent to about 526 of these procedures each day. As somebody was mentioning prior to this presentation, there is the Correctional Health Department has an item in their screening tool where they can document opioid use as being self-reported by the individual at intake. The statistic shows that 23% of the individual screened reported opioid use at intake in 2023. And you can see the increase year over year from 2021 to 2023. Transition Services is a team that has the very important task to ensure that services are available upon the release of inmates, those persons that have complex health challenges, have serious mental illness or chronic health conditions, and homelessness. This service becomes critical as it locates community programs that can help find the continuation program that can, again, help sustain the gains achieved while being incarcerated. And again, hopefully have an impact on reducing the risk of reoffense. On page 32 starts the analysis of the mandates. And our analysis concluded that except for optometry, all services provided by CHS are considered mandated. They're enabled by federal case law and by state statute. Optometry is considered a non-mandated service that supports a mandate, in this case, the healthcare mandate. So while there is not a specific rule that requires optometry services at the jails, optometry is considered a service that supports the healthcare mandate. Moving on to the last piece of the analysis, the cost part. We determined that in fiscal year 2023, roughly 80% of the expenditures of the Correctional Health Services Department represented detention fund monies. The table shows that of those,
Monica, I think we might have lost your sound.
I can hear you. Can you hear me?
Oh, we can hear you now.
Okay, very good. So yeah, the power went off and came back on, and I'm almost done. The table shows that acute health care accounted for $19 million, or about 24% of the total detention fund expenditures of CHS in fiscal year 2023. In the page 37, we are, just like we did for juvenile probation, we documented the trend of detention fund expenditures over the last 4 years. And as Sam alluded, the increase is attributed to the lower staffing levels and the overall higher cost during the COVID pandemic. And at the bottom of page 37, there's a graphic that shows the breakdown of detention fund utilization versus other sources. And we thought that that this would be relevant to see the impact that detention fund monies have over the provision of these very critical services. And that concludes my piece. And Stuart, you can continue.
Barbara?
Thank you, Monica.
Oh, just a second. We've got a question before we turn to you, Stuart. Barbara?
I have a question on page 36, when you do the breakout. What's included in administrative support?
Administrative support is a category that is actually determined to be mandated administrative. So these are generally administrative type functions and activities without which the mandated service could not occur. So that generally includes the functions of the administrative functions, procurement, technology, accounting, administration, quality assurance, all those things that, without which the mandated services could not be carried out.
Thank you.
Mr. Chairman?
Yes.
Jason, please.
On page 31, sorry if I missed this description, but I think I'm not tracking. On the description of self-reported opiate use at intake, the table is describing the number who report on opioid pain medication. Is that to mean lawfully prescribed medications, or is that looping in those that might be using an unlawfully acquired or off-prescription use of an off-the-shelf or prescribed medication? I'm just trying to understand exactly what that table is trying to tell me.
Yes, and I believe it is a mix of the two, the legally prescribed and the misused or non-prescribed medication. But if Director Struble is with us, if she could clarify that, would be helpful.
So, Mr. Chairman, I would like to get clarification on this. Looking at it right now, I do think it's a combination, but I also think that the prescribed medications may be addressing those already on MAT treatment coming in. So not necessarily like, we've gone to the doctor ourselves and we've prescribed an opioid. It might also be the opioid management with, withdrawal management or addiction management. So, but I would like to clarify that, and I'll get that information to Danny.
Then I would understand the remaining 75% would be like assumed to be the illicit substances or other. Is that right? Or you can wrap that into your answer later, but just so I got it. Yeah.
I believe so, but I'll verify. Thank you. Yeah.
That last row is the percentage of individuals that reported being on opioid pain medication compared to the total number of screenings. So in fiscal 2023, of 8,096 screened, 20,400 or 26% reported use of pain medication.
Okay, thanks.
Yes.
Before we move on, anything else on the correctional health services? Okay. We'll move to the alternate funding mechanisms, and I think, Stuart, you were about to speak when I interrupted you.
Yeah, that's fine. Good afternoon, Chairman and committee members. This section of the report discusses funding of detention and probation services in the state of Arizona and Maricopa County, as well as public safety funding policies and initiatives in other Western states. And this begins on page 38. The last pages of the section also provides information on the types of funding mechanisms used to construct jail facilities in Arizona over the past 15 years. The first part of the section discusses funding constraints imposed by state law that precludes Maricopa from using funding mechanisms available to other Arizona counties. First, Maricopa County is prevented from using a general use excise sales tax because the population is greater than 1.5 million. Also, the county's maximum jail excise tax rate, allowable per state legislative approval in 1997 and 2002, is 2%. That's 0.2%. That's 1/5 of a cent. Whereas most other Arizona counties with a jail district have a tax rate of up to 0.5%, and that's 1/2 of a cent. Also, Maricopa County does not receive any state assistance and pays for all of its adult and juvenile probation costs. Now, as part of this project, we also conducted inquiries in 4 western states, California, Texas, Utah, and Washington, and some of the state's largest counties as to how they fund their detention services. For example, counties in the state of Washington can enact various sales tax related levies to fund judicial and public safety services. In California, counties rely predominantly on their general fund grants, and state pass-through funding to support detention services. Now, alternatively, the state of Utah compensates counties for housing state inmates. And finally, the state of Texas provides funding for construction and jail and treatment-related facilities and mental health grant programs. And there's a lot more information regarding the states and counties in the text of this section. The inquiries conducted as part of this project found that all states surveyed allow their counties to utilize one or more revenue sources to fund public safety and detention-related services, including general use sales tax and excise tax, general fund grants, and direct payments. Which of the revenue sources and how they can be utilized by counties is determined by their state's legislature. In sum, we found that there's no uniform approach for funding detention services in judicial systems because each state's legislature determines what their counties can do. And this is no different than in the state of Arizona, where in order to change funding mechanisms in Maricopa County, legislative intervention is necessary. Thank you.
Any questions or comments? Thank you. And I understand we'll see some of you in person on October the 10th. Okay.
Yes, and we're looking forward to being there in person.
And we'll hope it all goes well with some of the weather challenges you're facing, but appreciate the information, and we will turn to agenda item number 9. And Danny and Paige, what do we need to know about agenda item number 9?
All right, Mr. Chair, members, I'll try and go quickly because I know we're getting low on time. So last week we had a lengthy discussion about these recommendations. We tried to take some of the conversation, update this document, and so we wanted to go through them again, discuss with you all, and then we'll do this again at the October 10th meeting as well.
So, Mr. Chair, members, good afternoon. I know it's been a long day. I will just read these knowing that we heard a lot today from you too, and we can wordsmith these things, and this is just kind of an open discussion so that you all can talk to each other and the public about these ideas we've heard you all mention. So we have 3 buckets: the programming and courts, and I would consider these, some of these are policy as well, capital recommendations, and then data and long-term initiatives. So the first one might have a lot to do with our diversion discussion we had today, but maintain sufficient funding for adult and juvenile probation departments. These funds help keep individuals out of jail facilities and support diversion programs that reduce the cycle of recidivism. In addition, it is a fiscally responsible use of taxpayer dollars. And then something that came up in the last meeting from one of our members, to be sure we're following best practices for community reentry and transition for individuals leaving incarceration or completing probation. And this can include strategic partnerships with entities that provide those services in the community. We heard today about the Medicaid waiver, so we put just a placeholder in there from knowing that it would be on the agenda today. And the language that we came up with is the county should participate with the state on changes to Medicaid waivers and continue to support federal efforts to amend the inmate exclusion for pretrial individuals. The third one was maintain a National Commission on Correctional Health and other best practice standards on substance abuse treatment and mental health programming. And finally, coordinate with the courts on the schedule of initial appearance hearings at the ITR to ensure that there is not a bottleneck created by individuals waiting to be seen.
Can we add one there? I know we're going to have time to do this in the next one, but I think to Marissa's point, a placeholder on prevention. And we can flesh that out. But
I was going to mention it, thank you, because it wasn't put on here and I said it last time.
Okay. Noted. Okay.
All right, so next, the capital recommendations. A lot of these are outlined in the jail master plan. So the first one, construct facilities to replace those that are beyond their suggested life. Estrella and Towers were the two that were noted in the master plan. The facility should adhere to current ACA standards and include appropriate administrative, healthcare, and pharmacy programming and staffing area spaces. Ensure there's enough capacity to meet the projected needs. The second one, increase security of the Durango campus and provide a clearer release path for those leaving the ITR. So that's another thing we heard about in the jail master plan. The third one, address improvements to the ITR that will alleviate congestion issues and increase security, including improvements to the intake area. Implement regular jail master plan refreshes in order to allow sufficient time for a comprehensive review, including that of staff and operations. And lastly, pending, so this is another, I should have put placeholder. There's another placeholder, pending the results of the juvenile detention facility assessment, implement recommendations to maintain the juvenile detention facilities.
And I would just like to add for our consideration, we can talk about it at the next meeting, to look at further at taking the juveniles that are currently in the adult facility that is not designed for juveniles and for them to be placed within the juvenile facility. This would reduce the staff that have to be taking care of juveniles in the adult facility, would liberate that staff to be able to do other functions like staffing the ITR so that area that had beds available for people to prevent further transportation. And it would also be in line with trends from the Supreme Court in terms of how juveniles need to be treated within the justice system more as juveniles versus treating them as adults.
Okay. Then the last one we've heard from many of you, the need for more data. So data and long-term initiatives, just consider forming an internal working group to coordinate criminal justice activities. It would have criminal justice agency, high-level employees, and as well as external stakeholders. And the entity could look at all aspects of the system, establishing uniform measures and data, starting with recidivism, to coordinate a definition on that because it's, definition is everywhere. Also strategies to increase diversion programming, adapting to emerging issues such as you all have seen about the substance use disorder issues, and also coordinating with other entities to improve public safety data like the Arizona Criminal Justice Commission. And because last time we talked about this, for the future, Danny and Paige have some public-facing element to it so that we can have archival documents available, because we found those very useful when we were preparing information for you all. And then finally, participate in the ASU study. You had a presentation about that a couple of meetings ago about the recruitment and retention efforts, and also, you know, to continue that ongoing discussion. One of you brought that up last time to continue talking about it, so that it's always an ongoing effort. So that's what we came up with those. If you all have any feedback on those or additional information.
Barbara?
I'd like to see a little bit more on linkages and the transitioning out of the facilities, whether it be the state facility or the jail. And that's with our treatment providers. It's a very complex web. And now that we hopefully will get the waiver, it becomes even more critical because, as you heard the county attorney talk about diversion, it's the engagement piece that if we don't have a person, you know, really right there and able to service the individual, they wind up walking out of the court and don't even make it to pretrial, for example. And I think that somehow we have to talk about that linkage to community providers, just being so critical.
To Barbara's point, the state is the one that has created the plan, the demonstration. And so the county has to really, all of those things that they say that they're doing are things that they have committed to before. But without the county having input about what that really needs to look like, then the deliverable isn't guaranteed. So I think that this is the area where we really can tighten that up. And with that, we need to add, I know that you've got data sharing here, but there needs to be data sharing between community providers in the jail so that that continuity of care can occur.
Mr. Chairman,
Please.
a suggestion, as I've been thinking about the working group and particularly that last bullet point on the public-facing element and archival purposes on that, I think maybe there is a need for maybe a second body, actually, because I think about the working group as more dealing with operational type issues and like working through how the place works and those kind of things, which I think also has a study and archival piece. But I think there might be value in our thinking about a more higher level body that actually just looks at the use of the dollars of the jail tax over time for an accountability purpose, rather than going into the weeds on how we operate and best practices. And they certainly can get updates on something like that, but I don't know that those are the same thoughts, and I'd put that out for the group to consider.
Okay. Marissa?
I think that's a good idea.
I think it's an excellent idea, primarily because if we were to lose the funding that we currently have, you would see pretty much the jail, adult probation, and juvenile probation and correctional health not be funded, and the county would be looking at astronomical costs. So I think it's a really good idea to do that.
Mr. Chair, if I could just make sure I understand. So we had the Citizens Planning Committee in 1997 that recommended to the board in their recommendations to have a Citizens Jail Oversight Committee, and that we talked a lot about that last time. So it would be an iteration of Citizens Jail Oversight Committee that you would be recommending to the board to adopt.
Yeah, I think something like that could meet like once a year, maybe twice a year, to say like, the county, you know, this much money came in, the county spent it on these programs, we made progress on the recommendations and the initiatives and whatever state mandates might be there. Thanks, we'll see you again next year. But at least then you've got the public record and some public visibility beyond what you might see just at the County Board of Supervisors annual budget meetings. Yeah.
Barbara?
Not to belabor a point, but last meeting, Jason, you actually spoke to, are we going to set some priorities? And I at least want to put one out there. Existing funds that, you know, now we clearly see almost all of them are mandated, and even the optometry one has to be done. I would, again, not want to lose this funding, and why it's so critical for us to maintain it, that we currently are investing a lot of money on good programs, and there are far more that need to be done.
Okay, noted. I might just add, from our last meeting, the three of us talked a little bit about a comment Chief Tobin had made about it was more community resources when someone leaves prison system, and wanting to make sure that we've got some good options and a plan in place. And I think we talked about that maybe part of our October 10th meeting. Okay, and then we can decide if there's actions on that. But okay, thank you. Any other ideas?
Mr. Chair, I'm just going to beat the drum again because I don't know how to do it, but after listening to public health and medical examiner, I hear us talking about prevention. It seems to me like the biggest drag is this mental health issue and substance abuse issue that affects the jails. And I don't know the answer to how to figure it out, but how do we avoid that population entering the jails? I don't know how to write it. I don't know the objective. And it's bold, I guess, but I'm thinking 2.5 decades, we probably ought to maybe do something different than what we're doing now. So maybe we can just come up with an objective that meets that very leftist type of a requirement or a need, to try and do something different than what we're doing today. I don't know the answer, but I just thought
I think Barbara has a thought.
I do. I think it's called strengthening our behavioral health system. And I think the more, as Dawn talked about it, the integration that we have to have as the largest county with our state entities and the biggest jail really becomes critical. But if we think it's difficult to basically retain and recruit detention officers, you have no idea how bad it is to try and get behavioral therapists and techs. There's a major shortage, just as there are nurses. So this staffing issue really becomes problematic because probation officers see the client all the time, and they might be dealing in the course of 18 months with 4 different behavioral techs.
Mr. Chairman, just one question to go back to Barbara's previous point, or at least what I think she was hinting at, is that we will have some time at a future meeting to talk about the funding alternatives in a little bit more detail and specificity towards implications for the county, so that we can maybe think about the recommendation for that element going forward. Is that right?
Yeah, okay. We will have an economist looking and kind of giving us an outlook of our options. I think that likely what we'll do is the October 10th meeting, we'll kind of talk about this, finalize this, do some public outreach, and then come back and talk about the funding options.
Perfect, thanks.
And adopt final recommendations after that, yeah.
That's good. I was just going to say, you all haven't voted on this yet. We're just keeping to compile it all together for what you're bringing up to us. We really appreciate the discussion today.
And would this be a summary from our calendar discussion prior? October 10th, we still have a few more presentations. And then we have 2 public forums, October 24th and October 28th, I believe. And then we meet again November 7th, which would probably be meeting to have some high collaboration. Does that sound?
That is our best laid plan currently.
Okay.
Yeah.
Okay. All right. Anything else for today?
Mr. Chairman, just for everybody, we will on the next agenda have Central Creative come and talk about the public engagement strategies for those 2 virtual meetings. Just so I'm not sure if we were going to have them there today, and it was a very heavy agenda. So it'll be on the next one.
Okay. And though, as you said, those will be virtual meetings. As a committee, we wouldn't come here physically.
Okay. 4th and the 28th, right? You're saying?
Yes.
And the 24th, I have on my calendar at noon.
It's at noon.
And the 28th is Monday, and I have at 6 p.m.
But that's not for us necessarily.
Those are virtual. Everyone's welcome to come.
Okay.
So in other words, we don't call a meeting, we don't call a committee meeting to order. It is a public forum. Though if committee members are available to hear the feedback, it'll be helpful. Otherwise, it'll be captured in written format.
Correct, yes.
Well, we will get an announcement.
Yes.
On that.
Yes.
Yes, Central Creative is working on a little bit of a toolkit too, so that you all have some, like, if you want to put it on your social media or send it out to your connected groups, the information. We're finalizing the Zoom calendar invites and everything, but yes, it will be, you will have all the information on those, as well as some information if you want to share it with the connections you have in this community.
Thank you. A lot of good discussion. And on that note, meeting adjourned. And whose family member just came up on it?